My name's Chloe Benn, and welcome to today's CPD Bites on child oral care. Today, our learning objectives will be to gain the foundational knowledge about child oral health, including the physiological changes, common myths, challenges in child oral hygiene, and its impact on overall well-being, to identify red flag symptoms that warrant referral to other health professionals, to understand evidence-based oral hygiene recommendations and self-care strategies for children, to tailor health recommendations to meet the specific needs of children, and to identify strategies pharmacists can use to promote child oral care in their communities and support caregivers in fostering a sense of responsibility for oral health in children. Maintaining or improving the oral health of children is a critical aspect of promoting their general health and well-being. Pharmacists often encounter young children before dentists do. Therefore, it is important to recognise common child oral health conditions. Early onset childhood caries or decay in children's teeth is really common in children below the age of 6. The American Academy of Paediatric Dentistry defines ECC, early childhood caries, as the presence of one or more decayed, missing, or filled tooth surfaces in any primary tooth in a child under the age of 6. ECC is probably much more prevalent than you think. In the UK, almost a quarter of 5-year-olds have decay, and around the world, it can be as high as 85%. In the UK, dental extraction is the most common reason a child would be admitted to hospital. Dental caries can be non-cavitating surface-level lesions or cavitated that penetrate the enamel. This widespread and aggressive condition can cause discomfort, pain and infection, and functional impairment, affecting a child's overall well-being. Pain can lead to poor sleep, and treatment for toothache can lead to absence from school and parents needing time off work. In severe cases, children may need tooth extraction, which can require surgery under general anaesthetic. The aesthetic impact of decayed and lost teeth can impact a child's self-esteem and may lead to bullying. The long-term consequences of decay in baby teeth increases the risk of future dental issues. It predicts decay in the permanent teeth that begin erupting around the age of 6. The loss of baby teeth can impact on the space available for the permanent teeth to emerge into, leading to functional and aesthetic issues. A quick refresher on children's tooth development. The primary teeth erupt around the age of 6 and 30 months, and then the permanent teeth erupt between the age of 6 and 13 years, and the wisdom teeth tend to come in from the age of 17 onwards. The clinical features of early childhood caries. The first clinical sign of tooth decay is a small softened area in a tooth's enamel surface, sometimes concealed between teeth or in fissures in the tooth. As the lesion develops, the decay penetrates the enamel, forming a cavity or hole and damaging the tooth underneath. Early childhood caries usually appears in the first 2 years of life as a white spot lesion that will then rapidly develop into a dark cavity. The oral implications of severe ECC with cavitated lesions can involve nerve involvement, abscess, swelling of the gums, tooth loss, and bad breath, and can possibly disturb the development of the adult teeth. The etiology of ECC is that the cavity-causing bacteria begin to colonize the mouth at an early age, and these bacteria form plaque, which is a thin biofilm that clings to the surface of the teeth. These bacteria metabolize sugars to form acids, which then dissolve the tooth's mineral surface. The longer the plaque biofilm remains on the tooth surface and the higher amount of sugar and fermentable carbohydrate in the diet, the greater the caries risk. The amount and particularly the frequency and consumption of sugar is the main etiological factor. In countries where dental examination and treatment is within a pharmacist's permitted practice duties, at-risk children can be identified through performing a basic oral examination. The mouth, teeth, gums, and surrounding tissues should be checked for dental caries, including these early white spot lesions. Looking at the oral hygiene overall, including looking for plaque accumulation. The continuous buildup of plaque can indicate a risk of tooth decay and will be more common in children with poor hygiene practices. Enamel defects are also a risk factor for tooth decay development. You should also check for the presence of any other oral disease, gum disease, or oral lesions. Diet is the most important factor in early childhood caries development. Fermentable carbohydrate in children's diet and the regular consumption of dietary sugar are major causative factors in the formation of tooth decay. This includes patients drinking prescribed nutritional supplements for medical reasons. Children over 1 year old who are using a bottle or breastfeeding are also at higher risk. Research has shown socioeconomic factors related to tooth decay, such as lower family household income and lower caregiver educational level, increase the likelihood of early childhood caries. Studies have found that systemic health conditions, including cerebral palsy, Down syndrome, and autism spectrum disorder, are also associated with higher caries experience. Dry mouth, which can be an adverse effect of medication, will also increase this risk. Ask about the common risk factors, as well as protective factors, such as toothbrushing twice a day with a toothpaste containing the recommended level of fluoride. And ask about the availability of routine care by a dentist and whether professional topical fluoride application is available. Good oral care should be introduced at the earliest age by example and instruction from parents and carers, so it becomes a part of the child's behavioural development. Pharmacists can educate caregivers to take their children to see the dentist as soon as their first teeth erupt and before the child's first birthday. This can help identify early signs of ECC and identify treatment and preventative factors. It can also help the child become accustomed to the dental team in a relaxed situation. Children should only be given water or milk to drink. The prolonged drinking of any sugar-sweetened drink, including carbonated or fruit-based juices or natural fruit juice in a valve-type feeder or any other type of lidded feeder cup, must be strongly discouraged. If any child is left unaccompanied with any type of bottle or container, it must contain only water to prevent prolonged contact with the teeth of sugary solutions. Dummies and pacifiers should also never be dipped in anything sweet. Pharmacists can instruct caregivers on the importance of regular toothbrushing, flossing, and other oral hygiene practices. Importantly, children should be assisted with toothbrushing until they can do it effectively themselves, which is around the age of 7, and they should be supervised up until that age. We can also recommend the application of topical fluoride varnish, and pharmacists can also apply this topical fluoride varnish to children's teeth to prevent tooth decay if your local health practice allows it. This is a really safe and effective preventative measure to strengthen the teeth. Pharmacists should refer on to dental professionals when necessary, when primary care treatment is insufficient. This slide gives a nice visual of the toothpaste and fluoride requirements for children under the age of 6. So children between the age of 0 and 3 years old should only require a smear of toothpaste on their brush, and it should be a toothpaste with less than 1,000 part per million fluoride, so about a grain of rice. But children between the age of 3 and 6 years old need about a pea-size amount of paste on their toothbrush, and this can be between 1,000 and 1,500 part per million fluoride. Teeth should be brushed for about 2 minutes, twice every day. And so for children, you can encourage this by playing a 2-minute song. It's also important to wait before brushing the teeth after consuming acidic food or drinks that can disturb the enamel surface. Also, not everyone realises that it's important to spit toothpaste out, but not to rinse it away. And this keeps the fluoride on the teeth for longer. Pharmacists should also recommend care when taking medicines containing sugar. Caregivers should be encouraged to brush their children's teeth or rinse their mouth with water after giving sugary medicines or supplements to prevent tooth decay. And as far as possible, pharmacists should recommend sugar-free options. It's also important that while breastfeeding in the first year of life is the best way to promote healthy development and growth of children, breastfeeding beyond 2 years can carry an increased risk of caries. Bottle-fed babies should be introduced to drinking from a cup from the age of 6 months, and bottle feeding should be discouraged from the age of 12 months to reduce the time that milk is in contact with teeth. Pharmacists should also be aware of the concept of dental neglect, which would be the persistent failure to meet a child's basic health needs, which would likely result in serious impairment of health and development. If you identify a safeguarding risk such as this, you should raise it via your local safeguarding processes. In summary, maintaining the oral health of young children is a critical aspect of promoting the general health and well-being. Early childhood caries affects children under the age of 6 years old, leading to cavities, pain, and long-term dental issues. Plaque bacteria metabolize sugar into acids, causing decay, and frequent sugar intake is the greatest risk. Educating caregivers on ECC prevention, promoting early dental visits, proper toothbrushing, and fluoride use, timely referral to dental professionals, pharmacists can improve oral health outcomes for children. Thank you.